All right, we are just working on trying to see if we have quorum here. Thank you for those of you who stepped through this with us in the last meeting as well. All right, it looks like we have quorum, and we'll go ahead and start record. Yep. All right. Good morning, everyone. We are going to go ahead and call the order at 10:30. Just a reminder, this meeting is being recorded, so everything said as a part of this meeting is part of the Bureau's website, posted to our YouTube channel. That includes anything in the chat or on the meeting itself. We'll go ahead and do roll call. Shall we? Brian Smith.
Present.
Brian Steven. Chris Albino. Dale Woolbridge. Dan Spade.
Dan Spade is here. My phone. I'm on.
Deb Grombe.
Here.
Esther Bissonette. Edgar, if you can unmute. Just say hey. Enrique Lopez.
Present.
Franco Castro Marin. Gail Bradley. Present. Dark Gamer.
Present.
Nina Shira.
Present.
Glenn Kasperzik.
Good morning, Present.
Thank you. Heather Miller.
Present.
Eve Godstanker.
Present.
Jesse Torres. Jonathan Maida.
Present.
Matt Shaw.
Present.
Nick L.
Present.
Ray Ochoa.
Present.
Ryle.
Is that Roy Riles present?
Roy Ryle. Thank you. Eric Harati. Shari Brandt.
Present online.
Phoebe Merrill.
Present online.
Todd Ariel.
Present.
Vince Martinez.
Present online.
And Vivian Gillard. We do have one. All right, thanks very much. Before we move down the agenda, I just wanted to take a moment to do a moment of silence. Unfortunately, this week we had the 2 line of duty deaths with Timber Mesa. And then also last month we had the air medical incident in northern Arizona with the loss of 4 lives. So I just want to take a moment of silence, please. Thank you. I believe it looks like Dr. Woolrich, I believe you're online as well, so we can capture your attendance, please.
I am. Thank you. Apologize for calling in late.
Not a problem at all. Thank you. I wanted to next say a big thank you to 2 longstanding members of the committee that are stepping down. Rod, I don't believe is online, but I do have the pleasure of really embarrassing Brian Smith. Who I know will love this. So Brian has been a very longstanding member of EMS Council for how many decades, I think now, Brian?
Well, I've been on the council for 4 appointments, so it'll be 12 years at the end of December. Education Committee since sometime around 2004, I think. I can only find minutes going back to 2007, so it was before that. And, you know, coming and participating, first meeting was September of 2000. So
25 years. So a big thank you.
25 years ago for this meeting.
Yay. I'm not sure everyone in this committee understands the amount of work that Brian has put in over the years on many of our other committees as well. He's been a very active member of several of our other committees, work groups. We can always count on Brian to participate, always keep us in line with what the rules actually say sometimes. So thank you, Brian, for all of your work over the many decades. We are going to start doing in May, for those of you who are kind of sunsetting off the committees, we would like to, as we do our recognition awards for the EMT Key of the Year and Trauma Awards in May, We are going to also do an award for those who are going from our committee. So we hope you will join us in May. If not, I know a couple people that will take that up to you and flag that, but big thank you for all of your work. So.
Thank you. It's been a pleasure.
Next, we'd like to welcome some new members to the role. Dr. Stevie Merrill has been appointed to a new role on EMS Council. She has been on EMS Council, but is now officially the Watkins representative, I believe. Yes. So position representative, which then points her to MDC, which has seen a long vacant role. So we're very excited to be able to have her in that position, as that has sat vacant for quite some time. Also like to welcome Matt Shaw, and then the reappointments for Sarah Parati and Heather Miller. So thank you for everyone's continued participation. For vacancies, there are currently 4 vacancies. There was a public member. There are 3 vacancies for this. And then the non-governmental employee of intermediate EMT that you were at the last meeting, we have 6 IMTs left in the state of Arizona. So we are very limited in opportunities to fill this role. So if you know anyone that may fill in that category, please let us know, as we would like to try to keep the council positions filled. If you are interested in applying, this is the governor appointed position. The link to the governor's board and commission website is on the agenda as well. A reminder about the attendance: if you do miss 2 or more meetings, the Bureau will reach out to you to see if you'd like to continue to serve on the council. And our updated 2026 meeting calendar is available as well. It is in your packet or linked to the agenda. We did try our best to avoid any large conferences. And if you see anything, please let us know. But hopefully we have avoided any of the main EMS and trauma conferences that go on nationally. Next, I will do the Bureau report. Nicole Witt is doing her civic duty and on jury duty. So she did allow me to say that, so she is not able to join us today. So I'm going to give the general Bureau report. This is in the packet, kind of a newer format, in a written format as well. So the Bureau Chief role is still currently vacant. Just a reminder, there is no longer kind of in-person walk-ins. If you have any business you would like to do with the Bureau, it does require an appointment to be made. You can do that either by email or by reaching out on phone. So sometimes we have individuals that want to come in to drop off an application or ask questions. You do need to make an appointment. We wanted to point that out to everyone, as we don't have dedicated office space on this floor any longer. With some updates, with just a reminder about certification. We have seen a large increase in EMCTs with expired state certifications. This has gone up dramatically in the last year. And so we're just trying to remind everyone that you have to have a Arizona state certification to work. So the organization is just trying to remind your personnel to kind of keep track of their expiration date. Anyone who has certification will get a 90, 60, 30-day reminder, but that is to the email that they have with their account. So we're just trying to put this reminder out to everyone, as we've seen an uptick in expired certifications recently. I will skip the trauma center review process, but this less specific to this. Strategic plan update. A big thank you to all of you that participated in our strategic plan development. That did go to the governor's office and has been now approved by the governor's office. So it is posted to our website and it's readily available. So again, thank you to everyone that did participate in that process. For service inspection update, we have a number of EMS dashboards that have been updated recently. We have our 2024 EMS data that is live. We just reviewed and approved the trauma dashboard. So that will go to the director's office for review and approval. And once approved there, we will also have 2024 trauma data live as well. EMS for children, we do have a new coordinator. That position was vacant, but as of yesterday has now been filled. So welcome Savannah to the team. Naloxone leave behind, if we can open that map. A big thank you to all the agencies participating. We have 66 agencies across the state of Arizona currently participating, over 4,600 EMCTs trained. We have almost 1,900 kits that have been scanned and about 6,900 kits that have been shipped out to agencies. You can see here on this map, I asked the team, can we get a map to see where the breakdown is of agencies, and really a very nice distribution across the state of Arizona of agencies participating in that program. So a big thank you to everyone who has supported this. A reminder with your agencies, if your personnel forget to scan the kit when they give that out, the QR code is the same across all kits. So they can go back to their truck or the station, scanned another kit. We just asked for very limited information. I actually talked about this at the national conferences. They were saying that a number of other states are actually requiring EMS to do an EPCR, collect a lot of data elements. We really asked for zip code and your agency. So very minimal information. So we wanted to make this as easy as possible for EMS to do in the field. A big transition for share. So I really want to highlight a little bit of this update. We have it a little bit further. We do have it on later on the agenda, so we'll go over in more depth. But a really big thank you to the entire team that worked on this share transition. Multiple who's here in the room, as well as Ann, Adam, and Josie. This was a monumental task when we took over the hospital side of the data for the share program and really try to modernize our data sets. To give you an idea, at the national level, there is the CARES registry. And the CARES registry is trying to do what this team has done in really about a year and a half. So I know we've had agencies waiting for updated share report, but this was really trying to modernize the data, take it in-house within the Bureau. So the hospital database completed their conversion over. And that is going really well with the new data entry system. And as of this week, we do have live the shared 2024 dashboard, including 2023 and 2024 data. We will go over that later in the agenda, but I just really wanted to highlight a big thank you for this work that went into this transition. So we will share all of that exciting data with you guys later on. There are some key safety resources on our website as well. And then just a reminder, if you're not currently getting Bureau communication, there is a link to sign up for Gov Deliveries. And then we do get quite a few questions. I get people reaching out to me to say, hey, I've got a certification or enforcement question. Who do I reach out to? Sometimes people don't want to put it in email. They want to call first. So we have on your links with some FAQs, direct email addresses, as well as direct telephone numbers. If you have any questions regarding certification or enforcement, that is where you can reach out to get that answered. So that is it for the Bureau report, unless anyone has any questions for me. All right, hearing none, we will go ahead and move to our standing committee and regional council report. Dr. Merrill, do you have a CHEPI report?
Sure,
Hey,
yeah,
Dr. Brett. Oh, you got it, Dr. Merrill?
I can actually do it. Yeah, can you guys hear me okay?
Yes, we can.
Okay,
Thank
great.
you.
Thanks. Sorry, I'm at work. But yeah, for TEPI, minutes were reviewed and approved. Adam was showing us the CEDAR and CARES and Red Cap progress. Looking for maybe starting a share user group. We went over the out of hospital cardiac arrest and PEAP slides, looked at heat data on the ADHS site, and then Vatsil showed us the EMS data dashboard for 2024. So that's what we got for trauma.
Thank you. Next, Brian, for education.
Right, thank you. We approved our minutes as presented. We have been working on updating and revising the formatting of training packages for STRs, and there was one presented for RSI, and that was approved as it was presented. There has been a work group that has been working on a training program for children and youth with special health care needs. And that was presented at our last meeting, and there was some concerns about some of the items that were in there. So another work group has been formed to go back and look at that and reevaluate some of the content that's in there. We have our first meeting on October 8th at 10:00. And then we approved forming a work group to make STR training module for the EMT IV. And their first meeting will be on October 2nd at 10:00. PMD.
Yep.
We approved our minutes as presented at PMD also. We approved an amended set of TTGs for maternal hypertension, preeclampsia, eclampsia. That will be going to MDC today. Approved an amended table to add labetalol and nifedipine. That goes to MDC today. Approved an amended drug profile for labetalol and nifedipine. Both of those will go to MDC today. Approved updated TXA drug profile to MDC today. Approved as amended some updates to childbirth. That goes to MDC today. And then one for general trauma was approved as amended, which will also move forward today. We did have an item to look at making the optional agents no longer have a minimum quantity requirement on that, and that was tabled until our November meeting. And that's it.
Thank you very much. Next for our regional council reports for Central Region, Royce.
Thank you, Doctor. I'll just defer primarily to the attached Central Region report. I want to highlight, we have a couple of big events coming up this year. One is the 6th annual EMS Fall Forum. There is a link in the report where you can go directly to that and register. It's a great CE event, and we've got some really nice speakers. And the other big thing is we're celebrating our 50th anniversary of AIMS. We have an event put together, and if you go to the website, there's a link there. You can read all about that and see the wall of people that have contributed to AIMS, and we'll be celebrating that toward the end of the year. Otherwise, the report is pretty comprehensive. Thank you.
Thank you. Next for Thames Region. I don't know if Sarah's on the line. If not, we have a report in our packet. No. Okay. We will skip to name then. It's actually Enrique now. Oh, all right, Enrique.
Good morning. Thank you, everyone. From the Western region, we're launching a new product. We're trying a new product called One Dose. This is a medication and dosage app. Bullhead City is currently spearheading the trial to get the program started in hopes to replace our current platform.
Oh.
And then spread it to the rest of the Western region for all users. We're also gearing up for our next upcoming provider assistance program. There's also a designated infectious control officer class, a DICO class in Kingman, scheduled for October 28th. And lastly, our next general WACMS meeting will be scheduled for November 6th in Yuma, Arizona. That is all I have.
Thank you. I think we had a little bit of miscommunication there. Vince, we jumped over you. Are you available to give a Northern Region report?
Yes, I am. Good morning.
Thank you.
I have submitted the names report for all to read. It's short and to the point, and the next names meeting will be on November 7th. Names would like to extend our heartfelt condolences to Timber Mesa and Fire Medical for the tragic loss of Brenna Kulikowski and Damon Thompson. You know, Timber Mesa, under the leadership of Chief Chevalier, have always been an engaged, active, and valued member of Names, and we support them through their grieving process. Thank you.
You. And then Dr. Woolrich for PACES update.
Yeah, thank you very much. We had our PACES meeting in July. We discussed and approved our minutes. We had a series of presentations. Antonio Hernandez presented drowning data to the committee. We had the Arizona Complete Health Crisis System presented and gave us information on resources in the Arizona counties, particularly focused on the rural counties. And we had another presentation from one of our colleagues in the Department of Health, Jessica Payne, on the high-risk perinatal program. The approval was focused primarily on our work groups that we set up. We are working into a joint venture with the Department of Education to update their Red Book. Their Red Book is a helpful handbook for school personnel, written at the layman level, for medical care, initiated on the on the school grounds. That is an ongoing work group, and we had our first work group meeting, and the next one is coming up. We welcome non-committee member participation in our work group, so if you're interested, please shout out to Shelley and Adam to get information on that work group if you'd like to join. We approved starting a joint work group with Committee on Education, and that'll be on child maltreatment. That will go to the Education Committee for approval and moving forward for their November agenda meeting. And we've also started working on excuse me, we have planned for our November meeting, exploring the concept of potentially working on a work group with pediatric behavioral health. That's going to be discussed at our November meeting. If you'd like to join us, again, we welcome non-committee member participation in our work groups. Thank you very much.
Thank you, Dr. Woolrich. Next, we will move to our discussion and action item. If we go ahead and present the minutes, if I can get a motion to discuss and approve the meeting minutes from May 8th. Thank you, Dr. Meadum. There's a second, Dr. Gamer. Thank you. We will scroll through those. Are there any recommended amendments? Hearing none. Any opposed? Any abstention? All those in favor say aye.
Aye.
All right.
Thank you. Next, we are going to move to our 2024 EMS dashboard. Vatsal, did you want to present? Sure. Thank you. All right. Good morning, everyone. We are seeing the same thing in 2024. It's on more than 1 million records now. That's we have started seeing in that few years. And this is what we see in 2024, 1.2 million EMS incidents were recorded through AZP years, which amounts to daily average of 3,400 EMS incidents per day. Now, number of total patients involved. So these are the number of EMS incidents. So there could be duplicates. So that one patient, 2 agencies comes up. They are recorded here as 2 separate records. So when we remove the duplicates and look at the patient level, that all then amounts to million records. So 1.2 then goes down to 1 million records. Since fatality, around 8,486 patients died on scene, which is 0.81% fatality. What you see on the top over here is that we have 4 filters available. We have a data from 2020. The last 5 years of data are now available. So we can kind of now do the 5 years of trend analysis using data. The EMS region is available. We can look at the regional level report by selecting Central, Northern, Southeast, or Western region. I also have the age groups available for pediatric. If you want to just look at the pediatric population, and then it will changes, and then it will tell us, daily like 230 pediatric incidents are recorded by EMS, with 245 of on-scene fatality. And then we have also the response time, so we can look at it, can filter it out just 911 or interfacility transfers and see what's going on. Majority of our calls are 911 response, like 80%, and then we have around 10% interfacility transport. That the volume, what you see over here is the volume by month, and it's pretty much same, around 100,000 a month. Ground is type of locations. We have 47% private residents, followed by medical facility, 25% EMS. Then look at the demographics. Again, we have the age filter available over here. If we want to just look at it pediatric, there was a request for a pediatric EMS report. So what we did is that we kept this filter available on each of the tests. So there is no need to create another pediatric report, but this entire report can then be filtered out into the pediatric group to show us the pediatric report. Incidents, EMS incidents by region, then we have the age group available. The number of incidents increases as the age goes, and then the below what you see again the EMS incidents by age groups. So one is the rate, 100 per 100,000 Arizona residents, and that we can see that it steadily increases as the age increases. But if we just look at the number of EMS incidents, which is in the below graph, then it kind of does not give you that exact picture, like, what is going on. And that's why we included even the rates over there on the top. We also have the county, the Bath County, how is coming up, even what we saw in our trauma report. We are seeing in the EMS report, although the Bath County has highest number of EMS incidents, either EMS or trauma. And by male and female gender distribution, there is equal use between the two gender. Whereas in the trauma, we saw that, male was higher compared to female. And we have a race and ethnicity background. American Indian have the highest EMS incidence rate specific. Similar picture we saw in trauma report too. Disposition now, this table, I know this is not how the categories are collected in ATPs by EMS agencies, but this is something like this ICD-10 code. We took it and we it goes through the standard metrics available by PMS and then and develop this category for the broader categories, meaningful categories. So what we are seeing is that the first one is not kind of classified anywhere, but mental, behavioral, neurodevelopmental disorders, you can see the 10% of EMS incidents are under that category. And so there are like injuries, again, 6% in 73,000 incidents were related to injuries. So this gives you a broader, basically, category. And also what we can do over here is that if I click on click it. Yeah, here we go. Yeah, and then it will give you, if you click on any of the categories, then it will change the age populations and the what happened to the position of the patient. So how many patients were dead on scene or transported to hospital, you can see it. We have a specific injury specific tab, and that's injury mechanisms of injury. Number one, falls, 68,000, 42% of the injury cases were falls. Again, which is the same thing in our trauma report also, the fall is the number one cause of injury in our trauma report. The struck by against is kind of going up, and we see more over here captured by the EMS database than the trauma registry, but in trauma registry also struck by against is one of the top 5 mechanisms of injury. And MVD occupant followed by MVD occupant. So see, we see more over here struck by against, and we see MVD occupant as a second in trauma, and that makes sense over here that EMS incidence is that not all struck by against end up into trauma, level 1 trauma center or a level 4 trauma centers, so that's why we see more, we can capture over here in ADPs more of these cases.
And just to explain for those of you who don't know how the data gets into different buckets, our state trauma advisory board data, that is patients transported to a trauma center. So that is how we capture that patient population. And if you think about it, any fatality on scene would not be captured in the SAB report, but would be captured in this one. So when you have different mechanisms with a higher mortality rate, those are more likely to be captured on this report because they aren't transported to the hospital, but EMS is certainly encountering those patients versus our trauma-specific report, which is patients transported to a trauma center. So,
right. And again, we should be able to select any mechanism of injury, and then we can look at the demographics of those patients. Then we have a tab for time-sensitive illness, and these are some of the illnesses chosen by the Bureau as a time-sensitive illness we want to focus on. And the first is by default is cardiac arrest. We can choose any one we want. Drowning. Click on a drowning and look at them. We know the age group 0 to 40. That's the age group. Surprisingly more male than female, which I don't understand, but yeah. And then the month is obviously summer month. We can see that. And highest amount in Coconino County, the rate wise. We can select, anything substance use. And we can see again that the substance use, we can see the age group down is in the middle. Air transport, we had around 25,000 air transport in 2024. That means that leads to daily average of 71 air transport.
And that's just air transport by year. We can see what we see over here. It's kind of slowly increasing over the years. By age group, the rate is more among elderly, but that's how the EMS incidents are also, the rate is higher among elderly patients. So they end up using more air transport. That makes sense. Obviously more among the rural, that makes sense again to the county because of the transportation issue. And there are air transports, mainly they were interfacility transports, and 21% were 911. Then we have a ground agency response time. So this particular tab is restricted only to 911 response calls. So there are interfacility transports were excluded from calculating the different time intervals. So what we see over here is the response time. The median is 7.5 minutes. Quartile 1 is 5.8. Quartile 3 is 10 minutes. So basically, up to 75% of the patients were transported, or no, not transported. The EMS responded within 10 minutes. That's what it means. Same time, they ended up spending around a median of 11 minutes on scene. And anyway, the range is between 6 minutes to 17 minutes. And then transport time also took another 10 minutes to transport them to the hospital. So that is one. And then we can select the region over here to look at the different regions. So maybe we may see a different picture and the central region should mimic almost similar to what we see the statewide, but maybe the northern region, we might see a little higher response time or transport time. And that's about it. And then we have a county specifics, yes, response time and transport time.
Thank you, Vatsal. So really, like I said, a ton of information. We are really trying to get the information about these different dashboards out there and kind of publicize it to everyone. Southern Arizona, the University of Arizona did actually use some of the data from our dashboards to apply and receive a very large grant from the federal government to support post-crash care. And so there is the opportunity, again, the post-crash care grants are specific for jurisdictions, so the Bureau cannot apply for those, but using some of the data can help support grant applications as well. So, thank you. We are going to keep up with the because we're going to move next to our sheriff dashboard and annual report. So as I mentioned previously, just briefly, as we pull up the share report, this has really been a big project to do this transition. And what we really wanted to do was to update and improve not only the hospital data, but also our EMS data. We wanted to make this a little bit easier for our hospital partners to enter their data, and then really try to make sure that we are in alignment with CARES, which is our national partner with our data for cardiac arrest as well. And so this is a little bit of the introductory page that went with this, that gives you some of the definitions that go along with that, limitations as well. Some of the pieces that we will start as we're now getting very close to our agency specific report. We really want to work with the agencies to figure out how we can address some of the data gaps. What we recognize, this is, I think, the first time that we've been able to really dial down to very specific information. So sometimes we see agencies where we see the percent of cases with cardiac arrest, shock, or rhythm, and then you look at the time, like minutes to actual defibrillation, and there's no data. So it essentially looks like for that agency that no patients got defibrillated. We know that they did, and this is where we want to work with agencies to kind of fix some of those data pieces. So this is, I think, really exciting that we can align with this. At our last meeting, someone actually looked at this and said, hey, can we break down our response time for and look at survival rate? And so Buffalo has already adjusted that, and we saw really a very specific breakpoint because we wanted to look and see if we look at response times, we had it at 0 to 4 minutes, 5 to 10, and their feedback was, can we break that 5 to 10 minute structure time frame up? And that's exactly what she did just in a few minutes, and we were able to really see big differences in terms of survival rate when you start getting into this breakpoint. So just kind of exciting to see what we can do with this data and how agencies can then use this data to potentially look for additional funding and personnel. So that is my introductory, and I will turn it over to Vatsal. Okay, thank you. Before I go into the data, I want to share a couple of things about the shared registry, like the advanced. What we did in-house is, when it was at the university and then we get transferred to state to us,
what we could do more than what before is that we already had AZPOs available with us, and AZPOs is now it's available in the Snowflake in a real time, fact available to us to do the data analysis. So that actually really became very useful for the shared registry. Is that I do have now cardiac arrest data live all the time available with me in front of me. How can I make this hospital data also integrated in such a way that it's also available lifetime? But not a lifetime, because the hospital data takes a little bit time gap to enter. Every quarter we tell them to enter their data. So it is as much as like every quarter we have the data available. So we made that move, we made that possible to both of that got integrated in Snowflake. And so every quarter we are now able to give feedback to the hospital that, hey, these agencies have sent, are saying that these are the cardiac arrest patients and transported to your facility, but you have not entered those or not given us the outcome of those patients. So we are getting more, because of that approach, we are now able to get more outcome from the hospitals for those cardiac arrest patients. And then the other thing we also implemented is machine learning leading to the linkage of the patients between AZPOs and hospital, which we used to do it. Before that, it was all some kind of a link software linkage, but mainly it was a manual. People going inside and reading each of those cases and matching them. Now we changed it into a machine learning, so it's all gets linked automatically as soon as the hospital enters the data, and then every month we link them against the hospital and AZPOs, and then we get the outcome for those patients. So my aim, once we have this annual report out and once we have the agency report out, we are gonna try to do this more in timely fashion so that we have hospital outcome data available more often for us to present to you guys. So what we had, these are the total cardiac arrest cases, 11,818 for the year of 2024. We do have 2023 also available here. These are the statewide cardiac arrest cases, not necessarily shared populations, but overall all the cardiac arrest cases entered into AZPOs. These are the exclusion criteria over here. If there is no resuscitation, then they were excluded. They were already dead, means there was no resuscitation, there was a chance for resuscitation. Then DNR, then they were excluded. There was some, we have a data quality issue, just 292 cases we had disposition incomplete, so we couldn't figure it out whether to include or not. So total 4,478 cases were excluded, which leads, that's where our shared population comes from. Those 11,000 cases, 7,340 is shared population. Transported to the hospital, 4,577 were transported to the hospital, and the remaining basically EMS termination of resuscitation. So either they get transported or there was a termination of resuscitation. Those who transported, how many went to CRC? 77% went to CRC, 22% went to non-cardiac receiving or referral centers. As we don't collect data from non-CRC, they don't submit hospital level data to us. These 1,031 cases, we didn't have the outcome, but we were able to capture the outcome from the key PCR available in AZPOs, because they do mention if they have the outcome at the facility, what happened, they do put it in AZPOs, and that way we were able to actually find from the 1,300 cases, we were able to find the outcome. And 3,546 cases, then we were able to link 57% of the cases. So our goal is to increase this linkage more and more over the time by giving more feedback to the hospital. So finally, we had 5,500 patients where the outcome was available. Total 162 agency participating in share and 42 hospitals participating in share. The share population, as we saw on the last previous page, and then population with the outcome because of the hospital submitting data to us. When you see the patient filled outcome, 37% termination of resuscitation and 62% transported to the hospital. With the final outcome, we have 5.9% overall survival among cardiac arrest patients. Also have the upstream population available, and then we can select the upstream population. Yes, and then it will show us which population the survival is increasing from 5.9 to 26% in upstream population. Demographics, about those 7,340 people. These are the more among male than female. Age groups, obviously, as the age increases, we see the higher number of cardiac arrest rates. County, some of the rural counties are very high compared to the urban counties. And the mainly it is 68% was the presumed cardiac etiology.
And this was really, I think, an opportunity. You see about 11% were not recorded. This is, I think, an opportunity to do the education with our EMS providers because really we can address certain groups in terms of prevention of cardiac arrest and try to improving outcomes statewide. So if we know where the cardiac arrest is from, so we know it's cardiac, or do we think it's more overdose or respiratory, other opportunities to do some more education prevention measures out there. So that is a field that we see not recorded. That means it's just left blank or unknown as put on the EPCR. So that is the reason I kind of try to teach of why we want that information, is because that really gives us a broader view at the statewide level about what's causing cardiac arrest death in the state. Now, field characteristics. This is the percent of patients with presence of witness. We had 58% unwitnessed cases, bystander witness 31%, and EMS witnessed 11%. And then, who received bystander CPR? 57% received bystander CPR. And if they received bystander CPR, who was the bystander CPR provider? And that's the breakdown we over here, a layperson or a fire responder and non-EMS fire. Median EMS response time was 7 minutes, and 23% of the patients achieved ROSC. And the percent of patients who had bystander applied AD, that was 7.5%. I think, again, when we look at a lot of prevention strategies, really the opportunity, only 37% of all patients in cardiac arrest get bystander CPR. We would really like to see that number much higher. So we do look at, our primary PSAPs, many of them across the state, especially in more rural areas, they are law enforcement PSAPs, not currently doing, CPR education or telephone CPR. So is there an opportunity to develop some of that with our 911 system? Obviously, the large dispatch centers are doing that and do have some type of EMD, but definitely an opportunity to increase that. Also, the AED use, only 7.5% had an AED applied. So we know that when you look at time to defibrillation, it's a median time to response time across the state of Arizona is 7 minutes, and someone has a shockable rhythm. Once you hit that 8-minute mark, their chance of survival is really down to almost zero. So we look at things like response time, AED use for potentially shockable rhythm, which is that upstream population. That's really where there is that overlap to prevent death in the field from cardiac arrest. So very helpful information to look at. And then the final page talks about only 5,500 patients where we have the outcome available. So that basically that which got linked to the hospital database, and then we had the final outcome available for the patient. So what in the center, what you see is a pie graph, and that talks about what was the final survival, and that's 5.9% of the overall Arizona state survival rate. And 50% were EMS termination of resuscitation unseen happened, and 43% died in the hospital. So around this, we have several bar graphs available, and each of these bar graphs basically are, you can select it to see the effect on the survival. So for example, if I want to see the bystander CPR and if I say yes, then it tells me yes, the survival from 5.9, it went to 7.2% if the bystander CPR is received. Similarly, if it is witnessed, and if I select the witness, look at the, if it is a witness, then yes, it has 10.6% survival rate. Shockable rhythm, obviously, if it is a shockable rhythm, we are going to see really high survival rate, and that's what we are seeing that 16 population, the same effect. Response time. Now, these response time categories are not available on our website. So this is, I just did it based on the feedbacks, but we will update it on the website pretty soon.
So we divided it into 0.4 and I mean, there are 5 categories. And if I look, what it tells me is that 47 plus 22%. These patients, that means almost 73% of the patients are we are reaching the response time is within 8 minutes. Then I have a 20%, 9 to 12 minutes. And then I still have around 9% of the patients who are more than 12 minutes. So, and we will see the effect of on the survival. So if it is a 0.4, right, select the 0.4, then survival is 6.8. So from 5.9, it went to 6.8 and 6.3. So it is higher among, even the response time is low, but if we look at the 9 to 12, it decreases to 4.9%. And then it decreases to 3.5%. So as the time increases, the survival for the response time. We also have the CPC scale available after the outcome, and 76% of the patients who survived, well, CPC scale is 1. And CPC is kind of the neurologic outcome. So you want to have a CPC score, ideally a 1 or 2 at the very lowest. Once you start getting to a 3 or 4, it's usually someone who's neurologically pre-devastated.
And is that how survived is defined as CPC of 1 or 2, or is it anyone that was discharged and still alive?
So
Okay.
if you see over here, I have 322 total incidents, and that's 322 you will see over here for the CPC.
I see.
We are really excited. A big thank you again to the entire team that worked on getting this data and doing this transition. This has been a big task over the last couple of years of moving this over and kind of updating this. And we have aligned the hospital data to align with the trauma center data. So we will be getting that on a quarterly basis moving forward. Some facilities do update that monthly, but really excited to have this. So big thank you. We are working on the agency level reports. I know there has been a big ask on that. We just want to make sure before we send those out across the state that they are in a format that you can kind of forward it as well. Because I know oftentimes people within one department may get it and they want to send it to department leadership, city leadership. So we are working on that. So we are hoping that to be available shortly. Any questions on the share report? For dashboard, questions, feedback?
I think the share report is amazing. I do have a question on the EMS dashboard. Can I go back a dashboard? I was curious if we have ground agency response times. I'm curious if we could add another tab that would be offload times for patients, specifically for 911 transport. How long from the time they arrived at the hospital will they actually transferred care?
I see. Okay. All right. Yeah. I'll put a note to it.
I have some thoughts on how we can break it down, but we can talk about that after.
Yeah, I think that would be helpful. Then we get back and forth, we can define it.
Yeah, that'd be awesome.
Sounds good.
Yeah.
Right. Thank you very much, Anton. Next, if I can get a motion to discuss and approve the draft Bureau annual report and operational plan. Thank you, Dr. Maiden. Second, Brian. Thank you. All right, it's 42 pages, so we are not going to go through every page. I promise you that, but I did want to highlight the snapshot, and this is definitely Julia's handiwork. I could tell when I looked at it, and she did confirm. So we're going to spend just a couple minutes going through this. I think it's really important information about our overall EMS system. When you look at the top of this snapshot, you see our total number of ground ambulance services to all of our CO1 holders, number of ambulances, number of inspections completed. We then have the certification numbers. So we have just under 23,000 EMT applications that were processed. And then below that, we see the total number of EMCTs. So you see just over 13,000 EMTs, about 8,300 paramedics, 182 AEMTs, and we have down to 6 I-99 states. So that tends to go down like one at a time annually. So there are very few left in the states, but there are a few out there. We have our air ambulance services listed as well. Enforcement, we have about 3 investigations that were open. Training centers, we see 118 total training centers and then 8 new training centers. And a great suggestion from our last committee, which was, can we produce a map of where the training centers are in the state as we look at kind of our workforce development. And so we are going to work on getting that made as well. Our grant programs are highlighted here. We have our FR grant, which is what funds our naloxone leave behind, our EMSC grant, which funds our pediatric program, and then the Governor's Office of Highway Safety grant, which helps fund our trauma database. So we have the number of EPCRs submitted to 80 peers, our data dashboard, we have 6, although I feel like it's way more than 6, but maybe it is only 6. There's just a ton of data available. We have a list of all of our trauma centers, our base hospital, and then we have our recognition programs at the bottom, our list of cardiac receiving centers, agencies who have been, excuse me, recognized by the MARC program, and then our naloxone leave behind data. Scrolling down further, you can see a really nice kind of stoplight fashion that this addresses our strategic plan that was put together. So kind of what's in process, what is needing more work, and what is not yet started. So really excited that the strategic plan has been approved. Shelley has me set up with contrast. Thank you, Shelley. Thank you. Keep scrolling there. And then we do have the budget as well. So you can see the budget that is included. The fiscal year 2026, covering all the different areas of the Bureau. And then thank you to our regional council, who also did include their annual plan as well. So we are happy to scroll through this. It is in your packet. If people have specific questions or things they would like us to spend more time on, we are more than happy to do it as well. This does need to be approved, so happy to answer any questions as they come up regarding this. Yes, Brian.
So what we're going to approve today is all 42 pages with the ones that aren't here, correct? Or however many pages that is. So I have a question, since I didn't see the plan for names. There is an item in there that is not going to go the way it's listed in there. And so I'm curious as to what that does, if we approve this today, what that does to names. It has to do with our provider grants and when they occur and how much we're giving away. But it was by April, $30,000 by April, and I'm not sure we're gonna have $30,000 this year. And we don't even approve provider grants until May. And then they don't get spent until, between then and the end of the year. So we're not gonna spend $30,000 on provider grants by April.
Okay. Yeah, that's what was submitted to me at the time that I requested it. So I'm sure, I don't know, Gail, what are your thoughts? I think in terms of approval, my perception would be that all of this will be going to the governor's office in terms of what we need approval for today.
I think as a regional council needed to submit an updated kind of summary to them. That would be, each regional council could do that as needed. I think the rest of the report is kind of set as it is from the Bureau standpoint. So does that work for you, Brian?
Yeah.
I think if he made it, I'm sure that's.
It's not like a super big deal, but it's just that I don't know how that came out to be that way. And since we don't even, award the provider grants until our May meeting, it would be impossible to get that. And the money may or may not be there. I'm not sure yet. Okay. And I really don't know yet. I don't think it's going to be as high as it says in there.
Okay. But yeah, if there are changes, we're definitely requesting.
Okay.
Just point of clarification. It's under operational plan, not a commitment, correct? So you're under no obligation. This is just the expected plan. Is that correct?
Correct.
So it's not a problem for us to approve it at this point, as far as I know.
It's not what, I'm sorry?
So it's not a problem for us to approve because this is an operational plan. So Brian's under no commitments for the numbers that's listed because it's only an operational plan at this point.
Yeah, I would say that's correct in terms of if there are plans on what's going to happen. If plan does not happen as written, which first things always, never go exactly as planned.
Okay, fine.
Yes. Thank you.
This is something we have not done previously at the Bureau, but we were told that we needed to do for some statutory requirements. That's why this is coming to the committee today for review and approval. It's one of the EMS Council's responsibilities. Any other questions or comments or areas people wanted to review? So I will say, is there anyone opposed to approving the annual report and operational plans? Any abstentions? All those in favor say aye.
Aye.
All right, thank you very much. Next, if we can get a motion to discuss and amend approve update to the Premier EMS Agency or PEEP manual.
So moved.
Thank you, Brian. Second, Dr. Mayor, thank you. So we can go ahead and project this. This is in your packet as well. One of the things that we have recognized with some of the recognition programs within the Bureau, including the Cardiac Receiving Center program, some of these people signed up for, and it was just indefinite, meaning they got this recognition and then it was never like resubmit to make sure you still meet the standards. And so we have developed a 3-year cycle for our cardiac receiving centers, just to make sure that the facilities were still committing to the requirement to be a cardiac receiving referral center, like with the data submission, having all the policies in place and transfer procedures as well. And so we really wanted to align this with our Premier EMS agency program as well as treat to refer to ensure that agencies were still meeting some of those state requirements if they did decide to do those. We had also added in, the council had previously approved the alcohol cardiac arrest data quality. And so agencies are getting those reports monthly to tell you kind of where there may be gaps in some of your cardiac arrest data quality as well. So this is the updated application process. This is really tried to be as streamlined as possible. And really the biggest change, I think, is the 3-year cycle for renewal. So we are going to ask if this gets approved today, that all agencies that kind of renew it, make sure, yes, we are still interested in participating in the program. We recognize that there's quite a bit of turnover over time, especially among EMS divisions. And so sometimes the point of contact that was over that program is no longer there. And so even more reason to update this. So that is the request from the Bureau for the council. We'll open up to any questions or comments.
In the category of PF requirements, number 2, committed and empowered quality assurance team that reviews 100% of incidents. Is there latitude to introduce AI into the review of incidents insofar as defining outliers that can be further evaluated by a team of reviewers? I bring this up because I know of agencies that find the requirement to review every incident of the second minute illness by a person. It's just an onerous requirement. I don't know if an agency, if they come with an application and say, well, we have AI that we're using to identify outliers that are further reviewed by a quality assurance team. Does that constitute acceptable review under this, would you say?
I mean, without getting into a proprietary product that's being developed, I would say that that's up to an agency to decide how they would like to do this. The QA, this is a voluntary program. So for time-sensitive illness and injuries, I think the council voted many years ago that that was kind of felt to be best practice for these type of incidents. There is 100% review of them.
Totally agree.
But again, that can be done based on agency, size of agency, resources. It's going to be done differently in different agencies. But I think that wasn't part of the any updates or changes to this. That's not being proposed by the Bureau. Typically the council wanted to propose changes to that, but it's not telling you how to do QA or CQI, simply saying that that's kind of the expected practice.
Thank you.
Any further discussion or question? Again, I think this was really kind of the biggest change, was making sure there was that 3-year cycle, just because we do want to make sure that if agency have this recognition, that they kind of still meet the standards for that. So I did not catch who made the motion to approve. I think the motion was Brian. Did you make the motion on this one?
Yes.
Brian did. I think Dr. Maida made the second of one. Thanks very much. Any other discussion or input? So we will go ahead and take a vote. Is anyone opposed to the update to the Premier Human Agency Program Manual? Any abstention? All those in favor say aye.
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 Next up is, can I get a motion to discuss and amend proof updates to the Treat and Refer Program Manual?
So moved.
Thank you, Brian.
Second.
Thank you, Matt. All right. This one, the couple updates here, one is again changing this to a 3-year cycle. What we recognize that the agencies again were approved a decade ago, and then there was no renewal to ensure that they still meet the criteria for this. We tried to streamline the application a little bit. For this one, we did also include links so that when you submit this with your medical direction information, you would just provide information about their medical license to ensure that they meet the criteria to provide medical direction. So just kind of saving the bureau team a little bit of legwork to have that information from the agency specific provider. So that's really the only changes to Treat and Refer. Those are the big ones. Cleaning up the language in the application, adding the 3-year cycle, and then just including the agencies providing their medical director information. Any discussion or input on that? Yes.
I just have one question on the AMD. It says possess current specialty credentialing in EMS and or emergency medicine, but that rule also allows for providers who have done an emergency medicine, an AFC GME approved emergency medicine residency. Now, probably most of those people end up being board certified, but what if they're not?
And
The
that gets into the next page of the process. So that includes having, this is taken.
No, but there is in this section here, it allows for somebody who has an emergency medicine residency also in the rule. I'm pretty sure, because when I do my base hospital
So
search,
if you look at 3, Brian, so it's saying if you don't have that, so they aren't board certified, then they have to provide the following, which is then the next page. So if they're not yet board certified, then it goes to their emergency physician in an Arizona emergency department and has current certification. So if someone did their residencies, they haven't taken their board yet, or they just don't take their board. To be an AMD, they would need to be working as an ED and have the ATLS Hauser.
I don't,
Yeah, that's not the way the rule was written.
that's the
Brian,
rule.
correct.
It does say, if you've done an AFC GME approved
board certified
emergency
or-
medicine residency or board certified or
For those cards, it's neither. It's, if you're working in the emergency department and you are not board certified and you have not done emergency medicine residency, you have to have an ATLS PALS.
what's that?
ATLS
No, I know, but it's not an and, it's not an emergency medicine residency and board certification. They're separate. I don't think that's a statute and rule book on my phone today.
Right now.
Brian, would it be acceptable to just say that they meet medical direction requirements under AAC R925-201-A1?
Well, that would seem a better, rather than defining that, just reference the rule. Yes.
Got the motion.
Which is, it actually says that in there. This is just giving you links to get that information. So it's actually kind of listed there on there, which is that meets the following medical direction requirements. So we reference that in there.
I know, but it said, but in 3, it does say if the,
This is, I think, was meant to be just a resource for agencies. So if agencies are trying to find that information. So I think we could probably just take off 3. And this is really,
take off 3.
yeah.
Yeah.
And then just, I think, essentially, if you eliminate that, we're basically saying you meet rule requirements, and then here's some links if you need to look up your doctor information. That's really what these 2 parts are, really supposed to be just a resource. So instead of saying,
Basically, the rule trumps everything
Mhm.
here, and it's stated that
Well,
you
I
have
just
to.
don't want people.
I know there's-
reading this document, you know, and they're not necessarily going to read the rule.
What you're
Right.
saying is
I think this is also they can contact Data Harden and say, hey, this is where we are, does this person qualify? This is a recognition program, so I think, this is supposed to be really a resource for agencies to say, hey, how do I find this information? Here's where you go click the doc certification, or it's not meant to be exclusionary by any means, but if you feel like it is, let's delete.
Well, I'm just concerned because 3 says that they're not board certified, they have to meet that other requirement. That's not really what the rule says. That's all I'm saying.
So we'll just, instead of a colon, we'll change it a period. And then it's just a resource below that. How about that?
Okay.
I think that it's instead of saying colon, then you're saying it implies that you have to meet the things after that versus period, and then here's the resources for that. I think
Okay.
you do have to have a medical license in the state of Arizona. Here's how you go find that information if you don't know how. And then if you just need to look up board specialty certification, there's the link to look that up. So. Then we'll delete 3, so it's not confusing. And then any questions, they can reach out to David Hart and he can help navigate ensure that their medical director meets the requirement. So. Thanks. So if we want to share that, like so the proposed edits of what's being displayed right now, where you see a colon there, that would be a period. And then we would delete 3. And then for 2, actually, instead of saying possess current specialty, you could just say confirm. So if you're looking to confirm that, so that would kind of imply if someone is not board certified, you could confirm that, but this would be where you gotta look, confirm that if you're looking for it, but it's not that you have to have it. Just then this is where you can confirm that data. And then we would delete 3 on. See, this is Brian, we're gonna miss you, man.
No, you're not.
I will. I like people. All right, again, you did good pick up on that. So. All right, this 5, those are recommended amendment. Are there any recommended other changes or questions about this? All right, we'll go ahead and take a vote. Anyone opposed to the update to the treatment referral programs? Any abstention? All those in favor say aye.
Aye.
Thank you. All right, next action item, with Ryan abandoning EMS council for better pastures. He has served as a liaison for EMS council on education and at PMB, so these are 2 separate items. And so he said effective January 1st, he will no longer be on the committee, so we will need someone else to serve on that. We do like to keep our those committees kind of balanced with our different regions to make sure all 4 regions are well represented. And Matt Shaw very kindly has offered to be the EMS council rep to those committees. And that way we still have an EMS council rep that is from the northern region there. And then that will open up his current based on those committees to another northern region representative. So trying to kind of keep that geographically split up. So we're certainly open for any other nominations that we will take from the floor. But thank you for Matt for being willing to step forward and to help cover those roles.
We'll take care of that at our February meeting. So hopefully there will be somebody here for March.
Excellent. So that is the current nomination is Matt Shaw to serve on education. But we'll take any other nominations from the floor.
Not too many,
Pardon?
but not too many.
All right. So I just need a motion to officially nominate and approve Matt Shaw to serve as liaison to Education Committee. Can I get a motion?
So moved. Second.
I refer this evening, second was Dr. Gamer. Thank you. All right. Any opposed? Any abstention? Matt, I'll take you abstaining. Thank you. And all those in favor say aye.
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 All right. Thank you. And then next, going into PMD, if I can get a motion to nominate and approve. Again, you're welcome to take any nominations from the floor. So I will leave that open. So can I get a motion to nominate and approve adding Matt Shaw as liaison to PMD? Thank you,
Second.
Brian, and second was Dr. Gamer. Thank you. All right. Any opposed? Any abstention? Matt, thank you. All those in favor say aye.
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 Thank you both. So that was, we just think you named ahead of time for voting on the next representative of those committees. So, all right. Agenda items to be considered for the next meeting. Does anyone have anything they have at this time that they'd like to bring up? Happy to take any topics now. Otherwise, you can email either myself or Shelley Bitzel. Yes.
I don't know where else this fits in. On the certification website, they're used when right after January, there was a place when I would pull up somebody's certification information where it has the critical care paramedic endorsement identified on there. So I could tell who had CCP with a state. That has disappeared. And also when I go to just looking at the different levels, there's a cell in there. You can go look at whether they're AMTs, IMT 99s, paramedics, there's a critical care. The first time I did that, there was over 360 or whatever it is, critical care paramedics that would show up. Now it shows up like 40. So I'm wondering if there's a reason why that information has disappeared when I go look up certs. Because I can't tell who.
Look at me, that's definitely not me.
Well,
like,
who would know, right?
I mean, could things change? I mean, with databases and stuff, things.
They're taking your
Maybe they know when I do a lookup that it's me. I don't know. Pretty sure. But that information has disappeared and apparently so has something else has happened. So like I know some paramedics I looked up before that were on the generic list, and now Matt Shaw shows up in there, but there's only 39 others, and the rest of the 300 and some odd people have all disappeared. And that doesn't show up on their certification information at all anymore either. I didn't know if there was maybe something going on that caused that.
No, thank you for bringing that to our attention, because sometimes when they do adjustments on the back end, not that the Bureau, because we don't manage image trend that way, things happen. Just okay, not really sure what happens, but we'll look into it. Thank you for bringing it to our attention.
So the endorsement is not listed.
Yeah, so it's got paramedic and their expiration date and what level it is. And then for a while there after January, there would be a spot where it would say critical care paramedic endorsement. That's gone, that line is gone
Yeah,
now.
we haven't intentionally changed that. So that's a,
Kind of thing comes here.
Well, it was like, I think it was over here, but it doesn't matter. It was up in this information.
We're
It
using
just
Matt,
said critical-
we're using you, Matt, to please get the information off.
Critical care paramedic endorsement.
Like
over
over
here,
here.
Like over here, let's say.
Yeah.
And so go, and so now go back. And if you look up the levels,
Yeah, and
there'll be critical care
It
paramedic and
does
select
have-
on that.
yeah.
And now it gets like 40 people when it used to give over 300 people.
Oh, thank you. That is.
Without a name, you just put in
You just put that in and hit enter.
Okay.
And it's supposed to pick up everybody at that level.
Okay.
And it doesn't do that anymore. It picks up all the other levels, but doesn't pick that one up again.
So, all right, we will definitely take that offline and follow up on that.
54 listed now.
Okay. There are like over 300. Yeah. So that's what I've heard anyway. There's over 300.
All right.
So, anyway.
Follow up on. Anything under call of the public? Upcoming events, there are a number of upcoming events listed on the agenda. Take note of those if you're looking for any educational opportunities. The Cardiac Arrest Survival Summit is in the first week in December. This is really a wonderful opportunity to highlight all of the work that is done across the state of Arizona for cardiac arrest care. I know Dr. Gamer, you've been actively involved in that committee, was kind of publicizing what's coming out. So do you have anything you'd like to add? Go ahead.
Thank you, Dr. Bradley. The Cardiac Arrest Survival Summit is a biannual effort of the Citizen CPR Foundation. This year, it's going to be held at the Arizona Grand Resort, for Ahwatukee area, on I-10 there. And it's going to be a great conference because there's some new guidelines that are going to come out for the first time in late October in many different areas of the resuscitated ARS. These are ill-corvetic guidelines that one of the first times they're going to be presented publicly is at this particular conference. And they're going to be done by the researchers themselves. So it should be quite a bit of added value there. It starts with a pre-conference, I believe, on the 2nd. And then the conference itself is 3rd, 4th, 5th, and 6th. There's going to be a lot of good survivor stories that are going to be told at a kickoff event on the Wednesday. You can go to the CPR Foundation or Cardiac Arrest Survival Summit websites and get early registration. There's a part of the, it's a fairly decent fee, but a lot of it's knocked off for early registrants and also for locals. And if you plead your case, then make sure that you're local and in part of committees that there might be some dispensation for that. Also, I've been out talking to agencies who wish to have apparatus in front of the concert venue or concert venue, conference venue. Tell where my eye is, but the conference venue for the gee whiz factor of it and to entertain the conference attendees, but should be a good time. A good learning opportunity for all. So thank you. Contact me, garth.gamer@phoenix.gov is probably the easiest way to express interest. If you have a question about registration, if you want to get involved, say with apparatus from your agency, please email me and let me know. Thank you.
Thank you. Our next meeting will be January 15th at 10:30 a.m., both in person and virtual. And if I can get a motion to adjourn, please.
Motion.
Thank you.
You like the ice? You like
full screen. Outside of the other stuff.